Director of the Division of Maternal and Infant Health. And before we get started this morning, I just want to share a brief note. I'm calling in from a hotel in Marquette, so I apologize if there is any street noise or hotel-related background noise that you all hear. Next slide, please. So I'm excited that you're all joining us today and welcome you to this Community of Practice webinar. We will be discussing the Mother-Infant Health and Equity Improvement Plan, and I have exciting information to share. We'll also be discussing the importance of being data-driven, both within our work as a state, region, county, local jurisdiction, and as well as your specific program if you are part of a programming effort that serves mothers and infants. We'll discuss engagement opportunities, so opportunities to connect with the work that's occurring throughout the state of Michigan regarding improving mother, infant, and family health. We will definitely have time for feedback and questions that will be facilitated by both myself and our state health equity consultant, Kenyatta Jackson. Next slide, please.
I'm sorry, this is Laura. I just wanted to say that this will be, this is being recorded so that we will put it on a website and it will be, you can share it later. So just an FYI that it is being recorded.
So as you're all aware, or I believe you're aware, our newest iteration of what was formerly known as the Infant Mortality Reduction Plan is now titled the Mother-Infant Health and Equity Improvement Plan, and will be for the years 2020 through 2023. And our overarching tagline, or I don't know, isn't necessarily a goal, but together saving lives. Next slide, please. So this is the exciting news. The Mother-Infant Health and Equity Improvement Plan was released today. It is posted to our website, michigan.gov/MHIAIP, and Laura can type that in the chat box as well. You will be seeing a press release come out from Dr. Khaldun, who is our Chief Deputy for Health and our Chief Medical Executive for the state of Michigan, in partnership with Governor Whitmer. Next slide, please. So the strategic visions of our plan and our efforts together are 0 preventable deaths and 0 health disparities. Michigan is truly a leader in maternal and infant health, and within that vein, or in doing so, we're making certain that we're taking things to the next level when it comes to the state of Michigan to improve the lives of mothers, infants, and families. Next slide, please. With that being said, you will notice, those of you who had reviewed the previous drafts of the Mother-Infant Health and Equity Improvement Plan, or Improvement Plan, that we've reframed many things based on the important information and discussions that we had with communities throughout the state, at town halls, at data meetings, at regional perinatal quality collaborative meetings, and as received through public comment and in other venues as well. And with that reframing, our focus areas, or 6 priority areas, you'll note are strength-based. So health equity, healthy girls, women, and mothers, optimal birth spacing and intended pregnancies, full-term healthy weight babies, infants sleeping safely, mental, emotional, and behavioral well-being. And with that, I'd like to point out that we've had questions regarding the fact that health equity should go through everything that we do, right? And it most definitely should. But based on community feedback, it was important that health equity be an actual priority area. There was some concerns that by stating that health equity throughout or utilizing a health equity lens could be misconstrued as somewhat watering down the effort. And by making certain that this is one of the 6 priority areas, we'll be committed as a state, as a region, as your program areas, as a hospital, families that are working together with us in this effort to make certain that we are achieving equity, and we're doing so in meaningful, actionable, sustainable ways. With the unveiling of the 6 priority areas, if possible, I'd like to hear your comments, feedback, reaction to the priority areas and any questions that you have at this time. So if you could enter those in the chat box, I'll give you a moment to type. Laura then will share those, and we'll have a nice discussion about them.
Great. So again, if you move your cursor around, you should have a black bar that pops up. There should be 3 dots and it says more underneath that. Click on that and then click on chat, and you can type to me, to everyone, and then I can read your comments. So again, your thoughts on the priority areas. Do we like do we like them? Okay, so Annie says, I really love the positive reframing of the messages and also the focus starting earlier with healthy girls, women, and mothers. Great.
Thank you, Annie. That's very important, and I appreciate your feedback. And most definitely those of us and all of you on the phone who work in public health, in clinical practice, community-based organizations, families, we know the importance of the life course and going upstream when it comes to improving outcomes. So beyond reaction, but actually going to primary prevention. And when we do that, that means that we're really focusing on, again, the entire life course or the entire life cycle, and doing our best as a community to come together and make certain that young girls and boys are in the healthiest possible state as they move through adulthood and into parenting, if those are the roles that they choose. And I see we have additional comments.
Margie says, I appreciate the calling out of health equity. I agree it needs to be a focus for all, but for it to be actionable and meaningful for women, infants, and families.
Thank you very much for that, Margie. And as I said, your comment echoes what we've heard from communities. And I truly believe that in order for us to address health equity, we need to actionably address health equity. So uncovering systemic racism, barriers to access, identifying social injustices, and moving forward with actionable efforts. And given that I have our health equity specialist, Kenyatta, on the webinar, Kenyatta, do you have any thoughts that you'd like to share regarding our efforts towards actionable equity for families in Michigan?
Sure, Dawn. I just want to make sure everyone can hear me right now.
Sure can.
Thank you. So I joined our team in December of last year, and this was partially an answer to the call to action to the state for a greater emphasis on health equity. And I have just had a tremendous response from throughout the state for different things, ranging from just introductory meetings and trainings to talk about just the 101 level concepts of equity, to more in-depth specific training on what we can do. So for example, and as many of you on the line may know, many people are interested in what is going on with providers and different services in terms of implicit bias for the community and certain populations in their communities. In some communities, these may be people of color, African Americans and Native Americans, and also there are equity-related concerns regarding poverty. And so the requests that we've had at the state level and the response that we've given has been varied and intense and continues. So Dawn, I would just add that we welcome everyone that's on the call, all of our partners, to make sure that you touch base with me if you have a specific health equity related question or a program need or some TA desire. We also have partners who support us in this work at the Michigan Public Health Institute. And my email is kjackson29@michigan.gov.
Thank you very much, Kenyatta. I appreciate the additional information as well as the importance of sharing your contact information as a valuable resource for our partners throughout the state so we can assure that we are moving in an actionable direction, an informed and actionable direction. Next slide, please. So with that being said, I mentioned at the beginning of the call that I was apologizing for any background noise given that I'm in a hotel in Marquette. The reason for that is that we are kicking off our 2019 town hall meetings throughout the state of Michigan and kicking those off on the day that our Mother, Infant Health and Equity Improvement Plan has been released. So our first town hall is here in Marquette this evening, followed by town halls throughout the state, ranging from the Upper Peninsula throughout Southeast Michigan, as well as I'd like to point out in Region 6, you see on September 17th, they are hosting an in-person town hall in Cairo in the evening. But then also they have 6 satellite locations so that all of their communities or counties that are part of Region 6 can participate. So they will be having satellite locations in Shiawassee County, Genesee County, Lapeer, throughout that whole area. And so I think that's very important that in the spirit of moving forward collectively, that was definitely very intentional to make certain that all the partners who are interested in being involved in the work can be at the table, whether it's in person or via webinar. As many of you will recall, we had town halls throughout the state last year in the month of July, I believe it was, and into August. And they were very well attended. People came out in droves, much higher numbers than we had anticipated, which was wonderful. And with that being said, they shared with us that typically the state comes around occasionally, you know, once every few years or as part of an assessment to garner information from our families and partners. And they wanted to make certain that we convened discussion groups and listening sessions more frequently. And this is critically important to make certain that policies, program implementations, decisions that are being made at the state level are being made in an informed manner. Because we at the state, the Michigan Department of Health and Human Services, we're here to support and you know, move forward the work of our local partners. And we can't do that without you know, like I said, informed or up-to-date information on what's being experienced in communities. Because when decisions are made without community involvement or input, that's when you know, incorrect decisions can be made with unintended consequences at times. So again, I'm happy to share that we're having the town halls throughout the state being kicked off today. And then you'll also note, given that over 40% of our babies are born in Southeast Michigan, which is Prosperity Region 10 that you'll see on the map, we are making certain to hold town halls in Wayne, Oakland, and Macomb counties. Again, in an effort to make certain that we have equitable representation from our partners throughout the state. Next slide, please. So a moment ago, I referenced regarding the town halls, the regions throughout the state, and those are currently called prosperity regions. And in Michigan, we have 10 prosperity regions. You can see those on the map. Another exciting thing that I'd like to announce is that in 2015, we had our first official Perinatal Quality Collaborative launch in Prosperity Regions 2 and 3, which is northern Michigan, and you'll see the star there in the center. They began coming together as a region around maternal and infant health in 2011, initially to address the closure of rural birthing hospitals in their region and what that what those closures would result in or potentially impact families, and they wanted to mitigate that. As I said, that was our first official region that was funded by the state of Michigan, and since then, so since 2015, we've had regions come together throughout the entire state. So regions 2 and 3 was the first. Region 10 was our second effort. Region 4, the third, and then again they've been evolving and occurring ever since then. But I'm excited to announce that you'll see stars in regions 7 and 9. So 7's the Lansing area, 9 is the Washtenaw, Jackson, Monroe, Hillsdale, Lenawee area. They now are officially regional perinatal quality collaboratives and will be funded by the state beginning fiscal year 20 that's approaching here in a couple weeks. With that being said, I think that it's really important to share that for those of you who are familiar with the terms perinatal regionalization, and those of you who aren't, I'll just give a brief overview. Perinatal regionalization was, for the most part, and is across the country, a clinically focused effort, and importantly, you know, a clinically focused effort to make certain the babies were born at the right hospital at the right time. And again, that's extremely important when it comes to medical care, to make certain that if a mother goes into premature labor, that hopefully she's delivering her baby at a hospital that has a neonatal intensive care unit. But we also know, as I mentioned earlier when I was discussing the life course approach, and Annie made the comment about the importance of going upstream, it's critically important that we unite our community and clinical efforts. We know that families do not typically reside in a hospital. They live in communities. We know the importance of local public health. And with that being said, our efforts in Michigan, rather than having one large state perinatal quality collaborative that's focused on clinical care, which is typically what occurs throughout the country, we change things up essentially, which is what we do in Michigan, and that's why we're leaders. As I mentioned previously, the fact that we do lead efforts when it comes to maternal and infant health, particularly maternal and infant morbidity and mortality. And with that innovation, we've went the route of having regional perinatal quality collaboratives. So we know that there are regional nuances in our great state. We have a combination of rural and urban, some areas that are strictly rural, some areas that are strictly urban. We're a state that has 2 peninsulas, which is obviously rare. And given that, we really need to tailor our efforts to our particular areas. And I know that even within a county, there's variation. I mean, from community to community. Those of you who've worked in schools, you know that there's a specific culture in specific school buildings, for example. So we know that there is variation that goes below the region, but we know that definitely breaking things down to a regional level is a much more tailored approach than having a statewide perinatal quality collaborative. And what we found, you know, through communication with our state partners, our regional partners, hearing from them, looking at patterns that families follow to seek medical care, to connect with community services. These regions that are listed on the map typically are the regions that that families utilize. Obviously, the Upper Peninsula, for the most part, minus the Mackinac Bridge, is self-contained. Regions 2 and 3, they came together purposefully and somewhat organically because in northern Michigan, that's how they work together. They come together as a 21-county region. Even though we have it listed as regions 2 and 3, they've decided to work together. West Michigan, very similar. There's differences, but yet there's similarities. When that regional perinatal quality collaborative came together, there was concern that there's, you know, so much variation between Grand Rapids and Muskegon or Mecosta or other areas within the region. But when they started to look at their data, hear from their community partners, they realized that there were many more similarities than there were differences. And as a result, have worked very effectively as a region to improve maternal and infant outcomes. So again, the regional perinatal quality collaboratives now represent all 10 prosperity regions in the state of Michigan. They work, if you're going to see a map that has cogs, whatever, in a moment, or circles, they work individually, but they work together. And with that working together effort, that's within the same spirit or framework as collective impact. So we work together individually as families, as a family unit, as our self-defined family. We reside within a community, work within our communities, and then work within our regions, within our state. So that's in the methodology behind having regional perinatal quality collaboratives working individually and then in unison as a larger statewide perinatal quality collaborative effort. And I would share that recently we had our Title V HRSA maternal child health site review in Chicago, and our federal partners, both at the HRSA level, at the CDC, are very interested in the way in which Michigan is uniting very purposefully community and clinical efforts, doing so in a tailored regional way, and then coming together as a state. So I mentioned that we're leaders. I also think that most importantly that we're going to see changes in our outcomes, our maternal, infant, and health and family outcomes in a much more drastic manner than what we would see if we continued upon our traditional path of the work. Are there any questions or comments in the chat box before I move to the next slide?
I don't have any. Does anybody want to type anything in? We'll give you a second or two. Okay, I'm not seeing anything.
Okay, next slide, please. I referenced a moment ago the importance of making data-driven decisions, both at a state level, at regional and community level. And with that being said, we have, at MDHHS, changed the way that we're doing business when it comes to data and releasing data both in a timely manner and then in a very precise manner, so that data can be seen at, as I mentioned, the typical state level, but at regional level, city level, broke down by demographic information, and importantly, teasing out data when it comes to disparities, so we can specifically see where disparities exist, both in from a population standpoint, but as well as in a demographic standpoint, so that as we move forward as communities, we can make certain that we're making informed decisions and choices and implementing efforts, and really importantly, removing barriers that are in the way of families achieving optimal health and well-being. And the data that I'm speaking of now was shared with the regions throughout the state in July, but it's also available if you go to michigan.gov/MCH, which stands for Maternal Child Health, and then EPI for epidemiologists. You can see all of the regional data as well as additional data sources and information. I'd also like to point out that, again, if you go to the michigan.gov website or MDHHS, you can see things such as community profiles, and I'll show those examples of that a bit on the next page. But specifically, there's information that's listed that you can really utilize and delve into, potentially find answers and or point you in the direction of areas of improvement. And I'd also like to point out that those of you who work in particular agencies or within clinical practice in hospitals and such, you also have real-time data for the most part prior to the data that's being released by the state of Michigan. So for example, I've spoken to many home visiting programs. We know what the infant mortality rate is in the state of Michigan, but I challenge those agencies or those home visiting programs to know what their infant mortality and morbidity rates are within their programs. Whether they serve 200 families or 500 or 100 or 75, it's important that they know the outcomes of the families that they are serving, again, so that they can address, you know, causes of death or poor outcomes, so they can build upon strengths, so they can assign home visitors in a manner that best supports the families that they're seeing. If you're in a hospital setting, you know, our hospitals in the state of Michigan, they knew that there was an issue with neonatal abstinence syndrome before it broke loose in the media on a national level or a state level. They were seeing increased numbers of infants who were exhibiting signs and symptoms of NAS or neonatal abstinence syndrome. They know the patterns of what's happening regarding what substances infants are being exposed to, changes in health and well-being of mothers. They know if they're seeing rises in moms for particular health concerns. So it's critically important that as much information as possible can be gathered from a variety of different sources, and particularly sources that are really nimble, so that you can quickly you know, identify or be aware of areas of concern, challenge, and importantly, areas of strength that can be built upon. I see that there are comments in the chat box. So Laura, if you could read those comments, that would be great.
Yeah, so Margie is asking about the town halls. She said, this is going back a previous slide, but could you talk about the goal of the town halls?
Absolutely. So the goals of the town hall, so there's more than a goal, there's multiple goals. Number one, and these aren't in order of importance, but number one, to respond to the request of communities for us to come back around and talk with communities. Secondly, to provide updates and information. And then thirdly, which is critically important, to have open dialogue and discussion sessions, listening sessions, so to convene community partners so that they can hear from one another, they can make connections, inform one another, create relationships, and again, within the spirit of collective impact, come together and work together. So for example, we've had instances where at town halls or larger meeting settings where we've pulled people together, where they've learned about efforts that are maybe occurring at their local birthing hospital or within a particular program that they weren't aware of. And so referral patterns can change, partnerships can be created, and you know, as a result, coming together and to achieve our purpose of maternal and infant health outcomes. Another, and I think most importantly, is to hear from families. Families have been coming to regional perinatal quality collaborative meetings. They were at data meetings that were held throughout the state in the various regions, and families were present at the town halls that occurred last year. And we're really hoping that that same presence and hopefully in greater numbers will happen at this year's town halls. It's wonderful when you have a group of professionals in a room talking about issues that many of us are well versed in. To hear from families, to hear what's actually happening in their homes, in their communities, and you know, it essentially change the course and direction as a result of hearing from the families. Laura, can you please? Thank you.
Sue asked if we could send out the slides afterwards. So this is being recorded, and it can also, it will be posted on a website and will also be sent out. As far as slides, John, can we send these out?
Yes, absolutely.
Okay, great. And then Alethea said, in relation to perinatal regionalization, does MDHHS intend to lead activities to assure Michigan birthing hospitals are in line with the ACOG and AAP neonatal and maternal guidelines for perinatal levels of care? Some work was done a few years ago in Region 10 that included birthing hospitals that indicated birthing hospitals were not fully in line with those guidelines as compared to their perinatal level of care designation.
So I'll share, thank you, Alethea. I'll share an overview of the levels of care that exist for birthing hospitals in the state of Michigan and discuss that in conjunction with the neonatal levels of care. So within the state of Michigan, we have, right now I believe there are 80, because we've had some hospital closures. There are 80 birthing hospitals in the state of Michigan, and they receive designation, to various levels, receive designation from what's called Certificate of Need in the state of Michigan. And if you're interested, if you go to the michigan.gov website, type in Certificate of Need, it will take you to the Certificate of Need website, and you'll be able to search for birthing hospital information. There's a host of other information on there as well about other areas that are regulated within hospitals, but particularly related to birthing hospitals. In Michigan, we have two designations. The first designation is the NICU designation, or Neonatal Intensive Care Units. That designation goes back to, initially it was the designation occurred in the 70s. I don't have the number in front of me, but it was 1972 or 1974. And the criteria for what was designated or what qualified a birthing hospital to have a unit being listed as a neonatal intensive care unit were identified. Our NICUs in the state of Michigan are not broken down by what the neonatal or the national standards or professional standards for levels of care. Our NICUs aren't broken down by levels 3 and level 4. So with the neonatal levels from ACOG, hospitals are broken down by levels 1, 2, 3, and 4. So I guess I should back up there to share that first. Level 4 would be a high-level NICU, and would be essentially, I'll give an example, but as I said a moment ago, Michigan has NICUs, so we don't differentiate between level 3 and level 4 in the state of Michigan. But for example's sake, Michigan Medicine would be considered a level 4 NICU. So they have critical care capacity, they have the specialists that are required to be considered a NICU that's level 4. They have the capability of transport for infants, as well as have neonatal surgical capacity to a greater extent than other hospitals with NICUs in the state of Michigan. Below that, so number 4 is the highest level of designation. Below that is number 3. And number 3 would be NICUs that aren't at the level of, for example, and I'm just using Michigan Medicine, I'm not trying to call or omit any other hospitals. We have several other hospitals in the state that have NICUs that would technically be considered level 4. The remaining NICUs in the state, though, so there's a total, I mentioned 80 birthing hospitals. There's a total of 20 birthing hospitals that have a NICU, or neonatal intensive care unit. The majority are what we would call a level 3. And not we, what the neonatal guidelines would call a level 3. And essentially that is a NICU unit, or it's redundant, but a NICU that doesn't have the highest level of specialization for caring for an infant, for example, with let's say a cardiac condition where they need to be seen by a pediatric cardiologist. So again, in Michigan, we have NICUs, essentially. So 20 NICUs, and they're not differentiated by level 3 and level 4. And again, that's been in place since the 70s. The next level per the national guidelines would be level 2. And level 2 in the state of Michigan is called a special care nursery. And when the guidelines for special care nursery occurred in approximately 2015, the guidelines for special care nurseries in the state of Michigan corresponded with the national guidelines. So the national guidelines had come out, and we made certain that as a state, as a certificate of need, that our hospitals or units that were designated as special care nurseries did meet those national guidelines and requirements. And essentially, for those of you who on the phone who aren't part of clinical practice or familiar with the levels and the information that I'm sharing now, essentially what I consider a special care nursery is a step-down unit. So providing specialty care that isn't necessarily to the level of a NICU, and yet the babies that are within the special care nursery have medical concerns of some sort. So they're not 100% healthy infants, if that makes sense, and they may have been born a bit early. Lower birth weight, they may have other issues, and that's why they're within being cared for in a special care nursery. The remaining and the bulk of the birthing hospitals throughout the state of Michigan are what we call well newborn nurseries. If you were going to correlate that to the national standards, that would be considered a level 1 hospital. So again, those are hospitals or units that birthing units that are for babies that are essentially, not always, I mean, but born full term, healthy weight, healthy babies. They do care for infants who aren't severely ill or critically ill. They can stabilize a baby and then transfer that child to a higher level of care if necessary. So as far as that's kind of an overview on the state and our area in the Public Health Administration, as well as Certificate of Need. We work closely together, reviewing the outcomes from the birthing hospitals throughout the state to assure that, for example, an extremely premature baby that's born in a well newborn nursery is transferred to a higher level of care hospital. But with all that being said, and I don't want to get into all the complete details, you can reach out to me directly and I can share more specifics, but there are instances when infants aren't necessarily transferred, and that's due to the safety of the infant, due to weather conditions and those types of things. So for example, I mentioned the Upper Peninsula, there's one NICU and it's in Marquette. The remaining hospitals are well newborn nurseries. So there are times when there may be a delay in transferring an infant to Marquette, for example, due to a snowstorm or something to that effect. In northern Michigan, which is Prosperity Regions 2 and 3, you'll recall from the previous slide, they have one NICU as well, and that's Munson Medical Center. So again, there may be instances when it's unsafe to transport an infant to a higher level of care. The transport may be delayed for reasons related to weather or stabilizing the infant prior to transport. So hopefully that answers your question, Alethea, but if it doesn't, would you please chat in an additional question or area of clarification that I didn't cover? And I'll wait a moment. Well, while we're waiting, Laura, would you mind reading the next comment?
Oh, I don't have any others. That was it.
Okay. All right, so with that, I will move on to the next slide, and I just wanted to share a bit about community profiles because these questions come up from time to time where our state consultants or other staff are asked about particular data for their counties, their jurisdiction, and many times this information is available on our website. So it doesn't require a data use agreement or reaching out for the state for a particular data query. So I just wanted to share that. I know that when I worked on a local level, I went here frequently and pulled information to make programming decisions as well as inform partners that we worked with. So this is a very long link that you can see up there, but it could easily be Googled, so you don't have to type that whole huge situation in. But if you go to, if you just Google Michigan Department of Community Health, which I don't know why it's still showing up under Community Health, but if you Google that, or you go to MDHHS and you click for statistical data, you'll see on the left it says reports, statistics, and health services along that, that left pane. You can come to an area that says Michigan Community Health Information. And if you click on the link, which you see the big red arrow there, it'll take you to the next page, which you can see to the right. And at the top, you can select a region. So you could select a state, you could select a specific county, a specific health department in their jurisdiction, and then specific cities, townships with populations over 10,000. And once you click on that, you can see a host of information from infant mortality rates, prematurity, low birth weight, birth defects, entry into prenatal care, teen pregnancy information. This is just an example. There's a laundry list of data that can be seen at a community level and as a state. And it's very important, or I think it is, if you pull for example, your county data, compare that to like counties to see where your county sits. You can compare it to the state. You can look, if you're looking at a particular county, so say you're looking at Genesee County and you want to specifically go and look at Flint or Flint Township, you can put that information in there and see additional information or additional data to help make informed decisions, as well as make decisions regarding programming or inform community partners. And I see that Alethia's comment came in. Could you read that for me, Laura?
Yes. Just wondered if the state had plans to assure those hospitals that designated as level 3 and really fall out as level 2 by national standards makes the necessary changes to assure women needing level 3 perinatal care get it.
Okay, so yes, we can definitely discuss further offline, but I'll answer the question just briefly. So as I mentioned, in Michigan, we don't have level 3 and level 4, we have NICUs. And if there's a NICU that's not meeting NICU standards by the state, so those standards can be found on the Certificate of Need website, the specific standards for NICUs to practice within the state of Michigan, that's followed up on by the Certificate of Need staff. And I've been a part of some of those conversations with birthing hospitals as being one of the nurse or perinatal consultants in that area. So for example, if there is a hospital where we see infants that aren't being transferred appropriately, or services aren't available for a child that should be at a NICU, that's followed up with the hospital and their hospital compliance team, and specific case and patient information is assessed at that time to determine if that was an appropriate medical decision and or if the hospital is out of compliance of being a NICU within the state. But as I mentioned, our NICUs within the state, that designation was created in the 1970s, and there are areas that do not align with the national standards or the neonatal standards, and that's continually assessed by the department regarding those areas. There's, and probably the rest of that we can definitely take offline as to potential strengths and challenges to moving in the direction of aligning with the neonatal standards. Okay, and Laura, if you would go to the next slide, please. Okay, and it looks like I'm having a webinar issue. I don't know if anyone else is, but I'm seeing a screen sharing starting up by Laura. Okay, and now I can see the slide again. So this slide I had referenced earlier, cogs or circles or something to that effect. So essentially, many entities, agencies, efforts working together to create, a holistic system. And essentially that's what's occurring with our efforts with the Mother Infant Health and Equity Improvement Plan, and efforts in general with maternal, infant, and family health throughout the state. It shows the Michigan Department of Health and Human Services in the center. By no means are we the central hub of everything. I really think that, quite frankly, if you go above, the community stakeholders and local public health are central to the work that we do. But you can see that our efforts include, as I mentioned, the Regional Perinatal Quality Collaboratives working together, our payers, Medicaid health plans, private payers who pay for services for families, both preventatively and in response to medical concerns. We have a group within the state that's called the Maternal Infant Strategy Group, and that group's made up of stakeholders throughout the state that represent various sectors, both hospital sectors, public health, health plans, faith-based organizations, community-based organizations, a host of individuals who come together to help provide guidance and leadership to our maternal infant health efforts. I've mentioned the town halls at length, and community input is critically important, both at the town halls, at regional meetings, and in any programming area within the state. That's extremely important that you're in touch with the families that are served. There are OB initiatives to improve obstetrical outcomes within the state. Those fall under work to improve maternal morbidity and mortality, both in the clinical setting. There's a variety of different efforts that are occurring where quality improvement projects are being conducted, standardization regarding care. So for example, addressing hypertension, high blood pressure, hemorrhage, cesarean section rates, and when decisions are made for cesarean sections to occur. So that's just an example, but there's many quality improvement efforts that are occurring around the state to improve outcomes for mothers within the state. And then the Mother Infant Health and Equity Collaborative, or MHIAIP, if you want to reference it by the acronym. That's our larger groups that we have that come together quarterly that include internal and external stakeholders, and they're held throughout the state of Michigan. The last one was held in Saginaw, and there was a very good presence, an average between on the phone and in the room of approximately 50 people. So not only do the partners come together to learn information and hear updates, but I think most importantly, they come together to communicate with one another, make connections, create relationships, because I've said this before and I truly believe it. I think when we move forward, that needs to and make strides and outcomes, relationships are at the basis of that. Not only communicating with one another, but having positive relationships where, you know, for example, if you are a physician, you know the name of a community partner that you can call up to refer a family to, or if you're at a local health department, knowing the hospital staff that work on the birthing units is critically important. So making certain that, again, that relationships actually, you know, are cultivated and are long-standing, so that we're all coming together to best serve families. Next slide, please. And with that, I am going to turn it over to Kenyatta to provide engagement opportunities and to lead additional discussion for the next 10 minutes. So Kenyatta, are you able to take the lead on the remainder of the presentation?
Yes, I am, Dawn. Thank you. So the slide says engagement opportunities, what can you do? And of course, all of you can do so much, but we have 3 suggestions on this slide that will help all of us become further integrated in this work if you haven't been to this point, or to continue. And one of them is to sign up for the Mother Infant Health Equity and Improvement Plan newsletter, which is located on the MHIAIP website, and the link is listed there just at the bottom of the page. Visit michigan.gov/MHIAIP. And you'll see a link on that page for the MHIAIP newsletter and other opportunities for engagement. As well, we suggest that you connect with your local regional perinatal quality collaborative, which, as Dawn mentioned earlier, are now throughout the state. I encourage you to attend the collaborative meetings, which generally are held on a schedule according to each collaborative's needs and pulls together partners from throughout the local areas that are working on the perinatal quality collaborative efforts. I also encourage you to feel free to consult with the consultants who work with the collaboratives from the Department of Health and Human Services if you have special requests or special needs that we may be able to support in your organizations. And I do find that sometimes I'll have health systems or hospitals make special requests, and their role with the collaboratives is a part of, us carrying out the plan, the improvement plan goals. Also, you can plan to attend the next MHIAIP meeting, which will be on November 14th, 2019 in Ann Arbor. And you can also visit the website to get more information on the MHIAIP meeting, including the speakers and the itinerary for that MHIAIP meeting. These are really informative, tend to go in depth in terms of presenting some special efforts throughout the state. And for example, the last MHIAIP meeting, we had a speaker that spoke on centering. So please feel free to attend the next MHIAIP meeting. As well, if you connect with your regional collaboratives, you'll find out even more engagement opportunities at the local level. At this time, I'd like to invite any questions or comments or any further questions or comments that the group may have.
So you can do one of two things. You can chat into the chat function, or you can raise your hand and I can unmute you. Or if folks have, if they're just on their phone, they can email me real quick. I'll monitor my email. Anyway, so Margie asked, I joined 5 minutes late. Has the new plan been published or released?
This is Kenyatta. As we discussed earlier, the plan has been released, and as of today, actually, which is perfect timing for the town hall meetings, the plan was released today.
Any other comments or questions? Also, if you'd like the PowerPoint presentation and you want to leave your email address, you can do that in the chat function or send an email to myself or your perinatal consultant. Any other questions? Any hands needing to be raised?
Mostly I'm seeing requests for the presentation.
I don't see any other comments or questions. And I don't have anything in my email right now.
Okay, Laura, I think we can move to the next slide, please. Which was just asking for more questions or comments. And next slide, please. So I just want to thank everybody and remind you that our ultimate strategic vision is 0 preventable deaths and 0 health disparities. And we look forward to continuing to work with you on these efforts. Thank you so much for making time for the call.
Thank you, everyone. I'll stay on the line just for another few minutes if you have anything you want to chat in. Otherwise, we will stop recording and get this on a website soon. Okay, so we don't have any comments or questions. We still have about 17 folks on the line. Please let us know if you need anything. Otherwise, we'll log off in just about a minute.